Kia ora, I'm Helen Fulcher, and today I'm talking with Linda Bryant, who's a clinical prescribing pharmacist, and we're going to talk about COPD, Linda.
Yes.
Now tell us a little bit about the key things you want to get across to primary caregivers today.
Well, COPD has suddenly become a lot more exciting. About over 5-10 years ago, someone would say, do you want to study on COPD? And I'd say, how depressing, which is not good. And so, I mean, it's probably been at least 3-4 years or so, we've had the new sort of devices, the new medicines available, but we've also learned a whole lot more about COPD and the different phenotypes. And I guess, there's a number of things. One is the role of the inhaled corticosteroids now, and really not there unless we've got people having a lot of exacerbations.
Right.
So that's sort of one of the changes.
Yeah.
Harder to withdraw them from people.
Yeah.
Although I've looked at our data and some of the practices, and we have a lot of asthma COPD overlap.
Yeah.
So, we can't wholeheartedly take away inhaled corticosteroids.
Yes.
I had a look, and almost 50% of our people had that overlap.
Yeah.
So, we have to be a bit cautious. So that's sort of one of the areas, the sort of changing of what we're doing. The use of LAMAs, so the long-acting antimuscarinic agents, have been really beneficial. If we look between them all, there's hardly really any difference except the devices.
So ease of use?
Yes, I guess that's the one sort of thing is you look at it, you can give them to the patients.
Yes.
And say, which do you prefer? And that's very nice to get buy-in. But I've noticed for some of the devices, there's one where you have to click it.
Yeah.
And so someone comes back and says, I didn't find this useful. So show me how you're using it. Open it, put the capsule in, breathe it in, and forgot to click it. So there's a few little tricks that we have to sort of help with people. So it is, what do you prefer?
Yeah.
The other thing is that try and get consistency. So sometimes we've had patients on about 3 different devices. And some of them are sort of a rapidly intake and others are a long intake.
Yeah.
So getting inhaler technique is really difficult in that. And so I guess that's sort of let people get comfortable with the device that they would like to use.
Yeah.
Don't get too hung up about the green aspect of the plastics.
Yeah.
It's
a bit impossible too with those things, isn't it?
Yeah, they're I think all of them sort of to some extent. So we run a very green practice.
Yeah. The future, it might change in the future.
Yeah, if they could be disposable,
as
in not plastic, it would be really nice.
Yeah.
But putting that aside. So a lot of that is to do with patient preference and some buy-in.
Yes.
And I guess the other one is the usual one that we have with most respiratory is getting people to use them regularly because you don't get an immediate effect.
Yeah. Yeah.
So that's incredible.
And so it sounds like you touched on briefly the education being really important. So clearly there are new drugs, new options, changing times with the steroids.
Yep.
And all of that is a conversation we need to be having with our patients.
Yeah, and that's why I think we've been talking about Leanne and that, and she's done some absolutely fantastic work.
Yes.
And her patients are so well educated.
Yes.
They can say amycloridium and tiotropium.
Yeah, which I can't.
No, giving you words around those ones. So she's done a lot of good work there.
Yeah.
And it is actually getting people to understand and not just saying this is going to help your breathing.
Yeah.
And people are interested in how they work, whether they're expanding their lungs or stopping them, contracting. So people do want to know, and they want to know to some extent how much more benefit.
Yeah.
So, is it going to really help their breathing? Is it going to stop exacerbations? So we're looking for really informed people. But it is that gap of trying to get them over. You've got to take it regularly or you won't notice effect. And expectations, if we say you're going to feel a lot better, that's sort of misleading them because they're not 100% perfect.
Yeah.
And so people go away and say, but I'm still breathless.
Yes. Yeah.
And so it's not working. Whereas you say it's going to sort of reduce your breathlessness. It's not going to take it away completely usually.
Yeah.
So I think it's managing expectations.
And when you look at it from a primary care perspective, are you talking about bringing these patients back constantly so that you're checking in with them, making sure they're happy with their technique, they're happy with how it's working, they understand what's happening?
Different practices and different situations happening.
Yeah.
We're probably lucky patients, it's free to come and see me, but not so necessarily for seeing others, but they can see the nurse.
Yes.
With the modern technology now, because we've got lots of the patient portal,
Yeah.
and were concerned at some point that some patients aren't going to be into that.
Yeah.
But I think a lot are. There's a lot of people. So even just reminders, sort of, how's it going?
Right.
Come back and pop in and see us.
Yeah.
So that's perhaps more for our population, which we're a very low-cost access practice.
Yes.
And I have a thing that when people come to see us, sometimes they've had to take time off work.
Yes.
They've had to get a medical certificate.
Yes.
It's taken off their sick leave. So we have to worry about how much we interfere with that. So if
Yeah.
we can do that to some extent electronically, do it on the phone,
Yep.
and just see how they're getting on. I always monitor by looking how many sort of relievers
Of
they
course.
buy.
Yeah,
or
that's right.
come back and get. So
Yeah.
I try and limit their reliever to one
Yeah.
so that I know when they want another one,
Yeah.
I know how long it's been lasting.
Yeah.
So they do use their relatives and
Yeah.
friends, but
Yeah. Yeah. Well, true.
at times. But that gives us sort of, is it getting better? So we monitor
Yeah.
benefit
Yeah.
and how often they ask for their reliever.
Has anything else changed in the COPD world other than the corticosteroids? Has the disease itself, and you talked about the knowledge around COPD.
Yes, and the different phenotypes.
Yeah.
You'll find now that the concept of FEV1 and percentage predicted
Yes.
is no longer the big driving aspect.
Right.
So function isn't actually driving our treatment anymore. It's
Yes.
being driven by the symptoms.
Yes.
And you can either do the COPD score,
Yes.
CAT score, or you can sort of do the MRC, the Medical Research Council, which is
Yes.
a bit faster. And actually get large symptoms and then look at their exacerbations.
Yeah.
So once people have got an exacerbation of 2 or more,
Yeah.
sort of over a year's 12 months, then it's going to be much more likely that they're going to benefit from an inhaled corticosteroid.
Yes.
I actually like looking at signals, not looking
Yeah.
at definitive things,
Yeah.
but looking at signals. I like to just see what the eosinophils are like, because that's recent work. It's come into the GOLD guidelines now at last. I remember
Yes.
Garrett first introduced me to that about 5 years ago.
Yes.
And so I like to, for my clinical understanding,
Yes.
is just keep an idea to where the eosinophils are going, because if the eosinophils are sort of above 0.3,
Yeah.
the expectation is that they could benefit from an inhaled corticosteroid.
Yeah.
Nothing's absolute.
Yeah.
So I'm just getting my clinical experience by keeping an eye on all our patients
Yeah.
to see if I can see a pattern.
And those guidelines you mentioned, where would we find them if we wanted to look them up?
GOLD guidelines are really quite good. Just put in GOLD COPD
Easy.
and it
Yeah.
comes up really well.
Fantastic. And asthma. You briefly touched on asthma. So
This
now
is
I
gonna
know
be-
it's related. So let's
Yeah,
let's
this
have
is
a
in
look
the-
at that as well.
Good, but a bit in the prescribing update. Again, in our very low cost access practice, we have
Yes.
a lot of people with asthma. I can tell you the exact numbers and that.
Yeah.
A third of them I noticed, just came in once a year, usually the beginning of winter, sometimes the beginning of summer.
Yes.
So a third of our patients were coming in, getting one inhaler, and it was a range of inhalers. Sometimes they'd get the beta-2 agonist, sometimes they'd get a
Yeah.
LABA and an inhaled corticosteroid, sometimes they'd get the inhaled corticosteroid.
Yeah.
And I sort of termed that myself as sort of a winter asthma. And then saw some studies, and there's 2 studies from overseas, but there's also one Richard Beasley's been doing. I like New Zealand studies. And it's using the inhaled corticosteroid and LABA as a PRN. So it's like a modified SMART protocol. So you might be sending them out saying, take 2 puffs twice a day and use this for your reliever as well. And I think we have to accept that they don't do the 2 puffs twice a day.
Yeah.
The evidence that's come out is that actually giving it to them as a PRN single inhaler is actually just as effective. They don't have as many exacerbations.
Wow.
Same number, it's not inferior.
Yeah.
They have this thing called asthma control days.
Yeah.
Not sure how clinically relevant that is. And so maybe there's less asthma control days. But
Yes.
I usually figured that was in a study and people probably did take it twice a day.
Yeah.
So I'm sort of thinking maybe we should
Yeah.
focus on those that have poorly controlled asthma and are needing their inhalers all the time.
Yeah.
And when you get this sort of winter asthma or seasonal asthma people, give them their one inhaler.
Yeah.
Go through a lot of education.
Yeah.
And don't stress too much that they haven't come back for
Yeah.
12 months
Yeah.
until they need their next one.
Yeah,
and
that's
that they're
right.
not regularly taking it.
Yeah.
So that's a little bit controversial, but there is there's 2 studies, and Richard Beasley's study should be out soon.
Yeah.
I think it's going to support that and focus where we can actually have lots of benefit, and those people are the ones that keep going into hospital. with
Yeah,
asthma.
which especially, as you say, in a New Zealand-based context is really
Yeah.
important. Oh, Linda, that's a whole lot of great
Sorry.
information, so thank you. And we're looking forward to all of that coming out.
Well,
Thanks
thank you.
very much.
It's been great.